Bismillah ar-Rahman ar-Rahim. Today we will continue our short videos. Today we will take station 3 cardiovascular examination. So we will start by you will enter the room, you will greet the patient and the examiner, go to the wall, read instruction and wash your hand. Then introduce yourself to the patient and take permission from him that you will examine him. You will start by general survey, looking for any clue. In clue, you may find oxygen cylinder in case of heart failure, some specific features in the patient like tall marphonoid feature, this is aortic regurg, ankylosing spondylitis patient like kyphosis, this is aortic regurg, Down syndrome, ASD, Turner syndrome, coarctation of aorta or pulmonary stenosis, Noonan syndrome, which is the male version of Turner, it will be the same. Then you start by hand, searching for clubbing and stigmata of infective endocarditis in the form of splinter hemorrhage, Osler's node and Genway lesion. To understand the difference between Osler node and Genway lesion, Osler node is painful, B-sized, purple in color, and present on the bulb of the finger, which is immunologic phenomena, while Genway lesion is painless and away from the bulb and sometimes present in the sole of the patient, of the feet. And vascular phenomena. Examine the palm for pulmonary edema. Then very important is the pulse. Check the rate, rhythm, volume, equality in both sides and special character like collapsing pulse. Never ever miss AF, it's a fatal. In head and neck, patient lying in 45, check for GVB. You can do hepatojugular reflux and also take permission from the patient. Observe carotid pulsation present in aortic regurg, which are called Corrigan sign. Examine for pallor and jaundice. The mouth for central cyanosis, dental hygiene, if high arched palate in case of Marfan. Then inspect the chest for any scar or deformity. Deformity like cardiac bulge means that this is from childhood. Then lower limb for any harvesting scar, any peripheral edema or any and the dorsalis pedis artery pulsation is palpated. Then go to the apex to start our journey in the pericardium. Start by the apex, we will palpate for site, character, and thrill. Try to localize it by 2 fingers and check its character. Is it heaving apex like aortic stenosis, thrusting like mitral regurg, or tapping like mitral stenosis? Left parasternal heave and thrill, palpable B2 and thrill, any thrill in aortic area. Then auscultate all area, mitral, tricuspid, pulmonary, aortic, and carotid. While auscultation, your finger should be on the carotid and tell the patient that you will do this. Concentrate and listen to heart sound and murmur. Commenting on character, radiation, area of maximum intensity, then the back for bilateral basal crepitation, any sacral edema, indication of heart failure. Cover the patient, thank him. These are the commonest scar you will face in the exam. Midline sternotomy scar. This will be with valve replacement, either aortic or mitral. You will hear click. If no click, it may indicate cabbage. There will be harvesting scar either in the leg or in the arm. Notice the 2 pictures beside it. Or maybe the patient has tissue valve. So midline sternotomy scar, no harvesting scar, no click, this is tissue valve. There is some indication for it. Or maybe non-cardiac cause like thymectomy, patient thymoma in case of myasthenia gravis. Another scar is left thoracotomy scar. This is for valve repair. Be aware because it's sometimes present under the breast, especially in females, so you have to take permission to elevate it, searching for it. Other scar in the below the left clavicle, which is pacemaker scar, due to heart block in case of myotonia dystrophica, ankylosing spondylitis, or Marfan. Be careful also for hairy patient, because the scar may be hidden in the hair of the chest, or although healed scar may be the same color of the skin. So take care of these. What are the common cases in the cardiovascular heart disease like aortic stenosis? So aortic stenosis, ejection systolic murmur radiate to the carotid. You will hear it in all the pericardium. So you will hear it in the aortic area, radiate to the carotid, and radiate down to the apex. You have to do Galaverdine phenomena and check if it is radiate to axilla or only in the apex and the aortic area. Why? To prove this is pure aortic stenosis. You hear murmur in the apex, maybe mitral regurg. So when you put stethoscope in the axilla, if no murmur, so this is aortic stenosis only. Listen and concentrate. Mitral regurg, pansystolic murmur, radiate to the axilla. Concentrate and listen. Mitral stenosis, this is difficult murmur. Mid-diastolic crumbling murmur, best heard in the left lateral position. Concentrate and listen. Aortic regurg, early diastolic murmur, best heard while the patient is leaning forward. And take a deep breath and hold it. You can diagnose it by peripheral signs: collapsing pulse, Corrigan sign, which is carotid pulsation, Droise sign, which is pistol shot in the femoral, Demoset sign, which is head nodding. This all can help you. VSD is a harsh holosystolic murmur on the left sternal border. You will palpate thrill. If you palpate thrill in pericardium, so there is a systolic murmur. And this is one of the signs of severity of the murmur. Concentrate, listen. Then prosthetic valve disease. There will be scar, midline sternotomy scar, and a clicky metallic sound. If it coincides with S1, this is mitral valve replacement. So concentrate and listen. Again, concentrate to the click. Come in the first. In aortic valve replacement, the click sound will coincide with SC2. Concentrate and listen. How to present a cardio case. You will comment on any scar or deformity, then BHM, pulse, rate, rhythm, volume, equality in both sides, and special character. Apex for the side, character, and the thrill. Heart sound S1, S2, is it loud, is it soft? Murmur, the character of the murmur. Radiation, area of maximum intensity, any maneuver done to increase the murmur. And comment on important negative like no signs of infective endocarditis, no AF, no heart failure, no pulmonary hypertension. If the patient on warfarin in prosthetic valve disease, no signs of over anticoagulation. So I give you example for a case presentation. I have examined this gentleman who is lying comfortable in bed. By inspection, there is no scar or deformity. The pulse is regular or irregular according to the case, and good volume and equal on both sides with no special character. Apex beat is displaced in the left 6 intercostal space and thrusting in character. On auscultation, first heart sound is soft, second heart sound is normal. There is a pan-systolic murmur of the apex which become louder in expiration and related to the axilla. However, the patient has no signs of infective endocarditis, not in failure. Putting all together, the top of differential is mitral regurg. Investigation of cardio cases. The majority of investigation will be basic investigation in the form of CBC, inflammatory marker like ESR-CRP. This will be high in infective endocarditis, renal function, and liver function. You may need UDS for hematuria in case of infective endocarditis, blood culture in case of suspicion of infective endocarditis. Investigation to confirm the diagnosis, most importantly to mention ECG and echo. ECG can give you an idea about arrhythmia, left ventricular hypertrophy, means the patient long-standing uncontrolled hypertension, or there is pressure overload due to aortic stenosis. Echo, the value of echo can give you, can confirm the diagnosis, can rule out other differential diagnosis, can rule out infective endocarditis, can detect ejection fraction, can give you idea about the valve gradient and chamber size. Chest X-ray in case of calcification or cardiomegaly. Then tailor investigation according to the case. If needed, case of HOCM we may need cardiac MRI, case of heart failure we may need pro-BNP, and so on. Treatment of cardio case, also keep non-pharma in your mind as your name. Patient education, patient counseling, stop smoking, avoid vigorous exercise. Due to HOCM, due to aortic stenosis, due to patient on anticoagulation, increase the risk of bleeding. Advice for lifelong adherence to the medication, especially anticoagulant. This is very important to avoid thromboembolic complication. And support like financial, occupational, and psychological, and so on. Pharmacological and surgical, as in majority of the cases you will face will be valvular heart disease. The mainstay of treatment is replacement. Either replacement or repair, this is some issue, this is according to some criteria. But you have to know symptomatic, so treatment is valve replacement. If prosthetic valve, the patient should be anticoagulated by warfarin, and advice for lifelong adherence to this, and also for the target INR. Be aware of target INR. Aortic 2 to 3, mitral M more, so 2.5 to 3.5. If associated with AF, maybe up to 4. So today we finish our cardio. I wish it's simple. Make it. I wish you get benefit from this session. Inshallah, we will continue our short videos. Still, we have to cover the neuro and the abdomen. Thank you very much. Assalamu alaikum wa rahmatullah.